This morning we'll be talking about, or we'll be learning on innovations in healthcare delivery in the peri-COVID era, implications for the Christian doctors. You all will agree with me that the recent health developments have in no small way affected the health sector worldwide. In spite of all this, it is no leeway to give God less than our best. We can't give God less than our best in our service to humanity. This calls for discovering more effective and efficient ways of providing optimum healthcare services. So this session is going to, at the end of this session, we should be able, praise God. This session aims to cause us to explore the various avenues in solving health issues. Challenges us to push beyond the existing and emerging constraints to effectively fulfill our calling as Christian medics. So without so much wasting of our time, I would like to invite our speaker, but I'll read a little citation. I'd like to tell us a little about him. He's Dr. Felix Ogedengbe. Had his basic medical education at the University of Benin City. He then proceeded to the National Orthopedic Hospital, Lagos, for residency training in orthopedics. He acquired further training in the specialty in Germany and in the United Kingdom. He is a highly esteemed medical director and CEO of Cedar Crest Hospitals, a modern multi-specialist medical center with branches in Abuja and Lagos. He combines his role as medical director with an active practice as a consultant orthopedic surgeon. He has nearly 2 decades of local and international general and subspecialty in orthopedic experience that has taken him to various countries, including Germany, United Kingdom, United States, Switzerland, Egypt, and South Africa, among others. Having served as a military orthopedic surgeon, Dr. Ogedengbe has a vast experience in orthopedic trauma and joint replacement surgery. Dr. Ogedengbe's vast experience and entrepreneurial skills have helped greatly in bringing great expert care to thousands of Nigerians. He continues to work tirelessly with specialists in all other fields of medicine in Cedar Crest to pursue the primary aim of ensuring that Nigerians no longer need to travel abroad in search of world-class healthcare. He's married to Evelyn and has 3 children. So with Jesus' joy in our hearts, we make welcome our speaker this morning, Dr. Felix Ogedengbe. Welcome, sir.
Yeah, a very good morning to you, and welcome to everybody who's hooked up this morning. Thank you very much for that introduction. Can I just crave your indulgence to give me 2 minutes? Let me just change my laptop. I think there's a problem with some of the slides on this one. So just give me 2 minutes and I'll be right back. Thank you.
to the water. So my soul is longing after you, as the deer pants after the waters. So my soul is crying out for you, as your heart is crying out for me. So my heart is crying after you, 'cause only you can satisfy me. Only you can satisfy my soul, satisfy my soul. Only you can satisfy me. Only you can satisfy my soul, satisfy my soul. Yes, only you can satisfy me. Only you can satisfy my soul, satisfy my soul. Oh, yes, only you can satisfy me. Only you can satisfy my soul, satisfy my soul.
Hello, good morning.
Only you can.
Good morning.
Morning, sir.
Can you hear me clearly?
Yes, sir, we can.
Okay.
Yes, sir, we can hear you.
Oh, all right, sir. So a very good morning to all of us, brothers and sisters. I'm glad to be here this morning. Thank God for life. Thank God for giving us the grace to get out of bed this morning. And I'm glad to be here speaking with the CMDA on this occasion. And my brief this morning is just to share a few things, and I'm asking that God will bless our hearts as we listen. I'm sure everybody realizes that the last time there was a pandemic like we have now was 1918. So if you haven't read about the details of the pandemic, Spanish flu 1918, you can also go do some reading about it, because it has a lot of lessons for the period that we are in right now. So I'm going to share my screen real quick. I believe everybody can see that. So most of it will actually be discussions, and then we'll take questions at the end. I don't know what your format is, whether it's written or verbal questions, but we'll just try and talk through the few slides that I've put up for this presentation. Okay. Can you see my screen?
Yes, sir, we can.
Yes, okay. Okay, that's fine. So that's the topic for discussion this morning: innovations in healthcare delivery in the PERI-COVID era, implications for the Christian doctor. As already introduced, my name is Felix Ogedengbe. I work in Abuja at the Cedar Crest Hospitals. So we're familiar with this strange virus. I think everybody who is working in healthcare has been quite inundated, or have had to be very careful about treating patients in this era because of this virus, which is a severe acute respiratory syndrome, coronavirus 2, also called the novel coronavirus 19. That's where the name COVID-19 has come from. First discovered in China, in the Wuhan city. Nobody thought it was a big problem until December 31, 2019. And then by then, of course, people thought that the WHO actually took it up very late. They declared it a global health emergency, January the 30th. And then by March the 11th, it had been declared a pandemic, which, I mean, it's been the first declared since 2009. But in terms of the enormity of this virus and of this illness, it really ranks close to 1918. That was the last large viral pandemic of this sort and nature. The first Nigerian case was seen and diagnosed here 28th February 2020, even though those of us in practice have looked at patient records prior to 28 February, and I believe that there are some patients who've been here prior to that time. So it's essentially a severe viral pneumonia. That's much that we already know. And it is good that we suspect it early. When you see patients, please suspect it early. If it looks like COVID, if it's COVID, you would have heard it said that patients say when they go to hospital, then the doctors say they have COVID, they have COVID, they have COVID. That is the safe thing to do. It's better to overdiagnose and over-suspect than underdiagnose and under-suspect. Ideally, you should have prompt testing and diagnosis. We know what problems testing have been. It's very difficult to get tests. I think most people who are in Lagos area, with the onset of testing with private centers, that has improved. And we're hoping that in the next few weeks to a month or two, that we'll be able to have private testing going on in Abuja as well. But in most parts of the country, testing has still remained a problem. Ideally, you have prompt isolation and treat. So you have what you call temporary holding areas where that should have, ought to have been created in all major hospitals still receiving patients at this time. And then patients are held there, PPEs are one, and then people are well looked after, and the risk of healthcare workers and doctors contracting the virus becomes low. And then from there, you ought to also move to dedicated treatment centers. If you're not doing home isolation like Lagos people are doing, or if the home environment is not adequate, then you go to an isolation center, and from there, level 1, 2, or 3 care, depending on the severity of the illness. So these are the kind of patients we are seeing now in the COVID era. The first category I put there, the non-infected general population who are in the community. This is where prevention really works. I do hope and pray that all of us are practicing the preventive mechanisms. There are people who feel that prevention is really naughty because they don't believe in the virus, or they don't think that it exists, or they don't think it spreads. I'm not really sure the reasons why, but all kinds of reasons have been adduced. Some are bordering on conspiracy theories. But in the community, there should be a lot of prevention going on. And there are 3 very key, very simple, important preventive mechanisms that work with COVID-19. 1 is the mask. 2 is wash your hands or sanitize your hands all the time. And 3, keep the space, keep some social distance with everybody else. If you're going to add anything else to that, I would say don't be physically in the same room with people for more than an hour, open windows and things like that. But 3 key things: 1 is mask, 2, wash your hands, 3, keep some distance from the next person. So from there, you now find we're having people in the community who come to hospitals with symptoms, and there's nowhere to go to. You would have heard stories about patients going around hospitals, and these hospitals have not set up temporary holding areas. We haven't responded. Let me just add here that we haven't responded to the COVID pandemic as a country should. When you're responding to a pandemic, you designate 2 types of hospitals: clean and dirty. So anybody who is suspected just goes off to the dirty hospital. Any clean hospital also keeps a dirty area or a dirty ward, where, you know, if anybody who has been in care is suspected to have the virus, they move there. But we haven't responded that way here. So all hospitals are open, everybody is taking things and then beginning to look at how to respond from there. So infected, once you have your test, then you're infected, no symptoms, that is community care or level 1 center care, which would be most of what people have seen being built by government agencies, isolation centers, tents, and all that. That is essentially what they are. If you're infected and symptoms are mild, you could stay in level 1 or start approaching level 2. If you're infected and moderate symptoms, abdominal symptoms, some mild difficulty in breathing, cough, things like that, you're going to level 2 and 3 are not for isolation centers. These are for proper hospitals designated for the purpose. So everywhere we live and where we look after our patients, we need to find the most relevant centers that fit into levels 1, 2, and 3, so that we are aware and we can send patients there or attend to, for them to attend to care there whenever they have to. By the time things are getting severe, so these are people who start to need some form of organ support. People who can't breathe well until they're getting oxygen flows of 10 to 15 liters a minute, and when they're critical, they have to be in the ICU. So intensive care facilities for COVID are relatively lacking, but we need to do a lot more. I'll come to the fact that that's some of the areas that we actually can begin to get things done. People who've recovered return to the community, and the jury is still out, the science is still out there, still gathering data on what has happened and what will happen to these people. There should be safe burial practices for those who unfortunately have died, so that people don't get infected. And I'm sure as Christian doctors, these are areas where we can actually also have a lot of impact. Whilst people are encouraged to grieve with people who have lost relatives and colleagues and all that, it is extremely not safe to begin to gather in those kind of events, because then the virus begins to spread again. And we're hoping that sometime in future that we may be able to get people to be vaccinated. That is a whole wide area. I'm not sure how many of us are involved in research or in virological research of any form of sort, but this is one area where we need people. We need Nigeria to also be on the map in terms of the countries that are actively looking for a vaccine. I think it's a bit odd that people are just waiting to buy off vaccines and all that, but I think that we should also be able to add to the science of vaccine production. Just a minute, trying to change that. So that's the where we now find a problem. We have a broken healthcare system, which immediately becomes, the result of that becomes a poor healthcare delivery. You would have an idea of what the maternal and neonatal indices are right now. Obviously, you know, low life expectancy, 56 years, males a bit less, females a bit more. The quality of care that Nigerians get in their lifetime is relatively poor. Ideally, in most other countries, even if not advanced countries, you have a record from birth, from the care you get at birth, which means you have proper neonatal indices when you're born, including your APGAR score or that. To the time you die, you have proper care. In between this, you have a GP who looks after you, a GP service of practice. And even when your GP retires, somebody else takes after you, takes off the work of looking after you. So we all, being doctors, work in healthcare in Nigeria. This is one of the problems. Unfortunately, we cannot fight COVID from where you ought to be. You fight COVID from where you are. You don't fight a pandemic from where you ought to be. You fight it from where you are. And where we are right now is that it has to do with all of these things that we'll put up here. Lifetime care is very, very poor in Nigeria. Record keeping as well is poor. Nobody knows how many people have been born or how many have died, and how many have actually contracted diseases. Over time, the indices are actually very, very poor. Then we don't do a lot of preventive health. I'm a surgeon. I like to operate, but I prefer that people are actually properly looked after, so that they don't get injuries, they don't get fractures, they don't get things like that. They don't begin to fall sick and develop intestinal obstruction. We need to begin to promote preventive care, and all of these brokenness in our healthcare system have actually been brought to the fore by the COVID era. We import everything. I'm sure most people know that we import everything. Now, these are things that will directly speak to the areas where I think that we can intervene. So I'll probably come back to this slide later. We import everything. Now, that's at the beginning of this COVID area in February and March, that became a big problem because we imported everything. Countries started to hoard materials and equipment for themselves, for their own use. And Nigeria had nothing to hoard. So we just had our hands up in the air, asking people to let us import, and of course they decided the prices at which we imported. One of the countries, China, where we bring our ventilators from, they have actually stopped exporting ventilators because they have suddenly realized the gap in their own system. And so the government has mandated the manufacturers to sell more ventilators locally. And they're trying to upgrade their own systems, update their own systems, make sure that even if a second or a third wave comes, that they are there and ready to cope. So if we don't do local manufacturing, that's a big problem that we'll continue to face. Of course, the general poor infrastructure, slightly better in a place like Abuja where I work and where I can get to work in 2 to 3 minutes. But in a lot of other places, you have to contend with bad roads, bad infrastructure and all that. Power supply, which is globally poor in Nigeria, and that tends to affect business a lot, and also tends to make sure that the equipment we buy do not last as long as they should. So these are all far-reaching effects. The risk of contracting the virus in the community and hospitals is quite high. So that's a lot that's really hitting us at this time, because people have very unsafe practices. If you go back to China and South Korea, for instance, it was fairly easy to control the virus because even before the virus came, people wore masks because of all the pollution problems and other viral flu problems they've had. And the fact that it's easy to tell people what to do and they do because they are fairly well educated, even Hong Kong. So those who said because China was an authoritarian country, that is not quite true, because the same doesn't hold for most of Hong Kong, and the same does not hold for South Korea as well. South Korea, by the way, is a democratic country, but people still obeyed. So once you told people what to do, they did it. But in Nigeria, if you tell people wear masks and they don't see somebody around to enforce it, everybody throws away the mask. I encourage all of us as healthcare workers to continue to use the mask. That has been found to really work. And then people, of course, died from the virus. Everybody in this forum right now can tell me, in the town they work, how many people have been successfully intubated and ventilated and recovered from COVID. I can bet you in any town or city, probably less than 10. Okay, so maybe a bit more in Lagos, but in most other places, you just won't find that service. So people died a lot and still die a lot from COVID. And from non-COVID issues as well. So people who had asthma. I mean, if you have an attack this time, it's going to be labeled as COVID. Nobody will treat an asthmatic attack. Nobody will treat a severe pneumonia. Nobody will treat allergy, because they all think that it all sounds like the virus that they don't want to catch. Of course, there have been stories of healthcare workers who have treated patients like that out of the goodness of their heart. And in one particular instance, the patient recovered, but the doctor died. And there are many other stories like that. So people are overtly careful, but that care has meant that we've had increased morbidity and mortality for patients who have suffered as a result of the fact that we're not really prepared. We didn't really have the rules easily, that people could easily apply and follow. So this has led to the loss of a lot of healthcare staff. One of the far-reaching effects is that we have patients who previously depended on treatment abroad to stay alive, and now they can't travel anymore. They've all run back home. They've not been able to go back. Some have actually died. And I've said earlier, the difficulty with getting the right equipment and tools and materials to give care, that has also been a very, very big issue. And that has affected care as well. So these are some of the far-reaching items. And there are opportunities for innovation, which is what we are trying to talk about here now. I'm not sure what our opinions are about some of these. Some of us may think that they are a bit extreme, but I think that for every failure, there's an opportunity. There's a reason why you want to be able to increase local care. I do hip replacements, and I've been to a town in France called NSC, where they actually started off that particular type of hip and knee replacements. And in that town, there are 5 surgeons and 5 engineers who sat in 1977 and then decided they would make these implants, and after years and years of trial, they were able to do it. And we have surgeons in Nigeria, we have engineers in Nigeria, we have all sorts of school people in Nigeria, tons and tons of them, and we have not been able to make anything. And it's only because of the COVID situation now that this has actually come to the fore. If we don't start by making orthopedic implants or other high-tech implants like that, we can actually start with smaller things. So in our hospital, for instance, we found the cost of masks to become very exorbitant, so we started to make our own masks. Luckily, we already have a small prosthetic production unit, so we could still use the same unit to do a few things, just move some tools around, and then be able to do a few things. So we need to strengthen local production. But let me come back to the first one, the local care, which I had started with, where we're not really doing enough for our patients. Most patients are having to go abroad for care. I'm not one of those who believe that, patients just go because they don't trust us. But the reality is that when you've traveled far and wide and seen what is offered at home, you see the gaps. And you wait until you are the patient who needs care. Then if you had the opportunities, you see what you choose. So I think this is an opportunity that has been forced on us. It's an opportunity for innovation. Everybody needs to go sit after this conference to ask themselves, what can we do differently? What can we do locally? We've been so minded to think only of importation. I mean, if you go to the Bible and read about the old Israel, which I've been reading for the last few weeks, they did a lot. They manufactured a lot. They looked after themselves a lot in terms of the tools of the day, in terms of the food that they ate and all that. But here we sit in Nigeria. We import everything. We want to import the food that we eat. We want to import everything. Gauze, why can't we make gauze in Nigeria? There used to be syringes and needles called Zariject because they were made in Zaria many years ago. But most of those industries have folded up. We would think that the government is not interested, but I'm not even sure that the people are interested as well. So let's look at increasing and improving on local care and local production, because patients are actually getting into a lot of trouble because things are not local. And like we've seen in this pandemic, that will always be the case. When there's trouble, people will keep their resources for their own selves. It's only when they have excess that they will sell. So, I mean, I have been asked about a patient who needs to do a PET scan, PET scan, positron emission tomography scan. This is, to give an example, the best scan to do, just to put it, I mean, some of us are familiar with the space of oncology, and so they will understand this. Just to put it mildly and nicely, generally, the best scan to do to know where there's cancer in the body. And it's the best scan to use to know where to do radiotherapy for. And there is no PET scan in West Africa. To have a PET scan, you need a cyclotron. This cyclotron develops the radiopharmaceuticals that the PET scan will use to see where the cancer is. And there is no PET scan in West Africa. The closest PET scan to us here is in Nairobi, Kenya. And then apart from that, you're going either to Egypt or you're going to South Africa. So where does that leave us? It means that if you have somebody who has cancer, you need to radiologically pinpoint where that cancer is in the body to treat. You will have to rely on some way, in some sort, on MRI or CT. That is less than adequate. So things like that just show that, goes to the third point, the entrepreneurial opportunities. I don't believe that these are things we can't do. I believe there are things we can do. We started our practice 12 years ago, not because we had money, but because we just felt this was the option and they were ready to take the option. And evidence has shown that lack of money to invest is not the reason, it's not the problem. There are opportunities for funding. May I remind us that we had shouted and screamed to the central bank over time to preferentially fund healthcare in Nigeria, but they started doing that as soon as this virus came by. So there's this healthcare intervention fund, 100 billion, which is the first tranche that the CBN has released, and they're going to do more. And apart from the CBN, there are other banks and finance bodies that are actually beginning to approach a lot of local players like us, asking for people to take up in-house, inland growth. So there is money. I don't think lack of money is the problem. I think the CDMA will probably do well to raise a committee to look at the particular areas, to drill down more in particular areas. There's money from Afrexim Bank, there's money from African Development Bank, and there's money from the World Bank as well, apart from our own local CBN. So I think there are a lot of entrepreneurial opportunities that we need to take, both for, and that's why I'm glad they said the PERI-COVID area, because both for the immediate and for the future, we don't expect, I don't see any way that health tourism is going to go back to the same levels that it's been in the next year or two. It's just not possible. So I don't think that we're going to leave our people just to begin to die. We have to start thinking of what to do. And I think that those people who have not been taking private practice, for instance, seriously, this is the time they need to start to think about it seriously and prayerfully. So there are opportunities, and if there are opportunities, I then begin to think that Christians should be at the forefront of these business opportunities. I work in the North. I know that a lot of regional and religious groups taking up opportunities in business right now as we speak. A lot of meetings, a lot of meetings, and a lot of deliberations about how local and regional groups can take out the business opportunities and gaps. It may also remind us that once there's a virus like this, then foreign direct investment in your country tends to dry up. People, first of all, before they come to your country to invest, they will think about the risk to themselves, the risk to their families who they might need to bring, and they will now begin to actually think of the risk, whether they want to bear it or not. But you are here, this is your country, this is our country, so we have to be able to take this. We have a lot of crime in our land primarily because, I mean, people have their ideas about it, but I think it's primarily because the employment opportunities are very, very few. And the employment opportunities are few because we have not educated our people. So you find that even when you interview people, you really can't get a lot of people to employ. But as long as these are people living in the country and they are not employed, they will take to crime. So we have to begin to think of employment opportunities that have come out of the COVID era. I mean, I can give an instance. We are doing, in our hospital, we don't treat COVID in a way. We did set up one, we did try to do that, but we have decided not to do much of treating COVID in our center in Abuja. But we are also now thinking of setting up a COVID hospital. We need to look at that because there are people who are falling sick every day. They need to be looked after. And so if you're out there, if you're listening to me and you're in private practice and you're not able to help in any shape or form with this viral illness, you may also team up with other people to say, can you try to start up something somewhere else? Because the concept that we use in the UK and elsewhere is the only thing that works. Even in China, they did the same. There are clean hospitals and there are dirty hospitals. Problems are more when you then try to mix them up, and begin to draw the lines, and people will always break those lines. So if you have a big practice and you have a smaller one somewhere that treats coronavirus patients, then you can always send patients from your big practice to that place. So apart from the fact that you get care to people, it secondarily protects your own care. So that's an advantage as well. So we've talked about the opportunities here. And I think that for us as Christians, first of all, we have to survive. We have to put our trust in God. I don't think some of us have been exposed to coronavirus from day one, and we haven't survived only because of the things that we have done or the things we've done right. But you have to primarily put your trust in God, and that's why I put that in bold letters. We need to put our trust in God. We need to begin to look at our job as a calling and as a role that we have to. You can't believe the quality of care, the low level quality of care in Nigeria with all of us here. So, and I don't think that is good enough. We have to do a lot more. We have to build capacity. Most of the younger doctors who run away to other lands out of this country because they don't have employment. If you don't have employment, you're young and you're smart, what are you going to do? You have to leave. Even if you have employment, then you begin to compare your employment here with what other lands can offer you. So it's not anybody's fault that they go, but we have to build capacity. I'm encouraging us to begin to build capacity, to think of coronavirus pandemic a blessing and not as a curse. Everybody here, those who are probably well-to-do, would have traveled for healthcare in the past and all that. And for me, everything you do for yourself abroad is like just hiding your head in the sand. You want to have your opportunities to do things. You will not say that I mean, it's not your fault. It's not our fault that you're unable to do things at home. We blame that on the government, but we look for other things, other ways to sort ourselves out. And that also brings me to the point that the way to build capacity sometimes is for Christians to start getting involved in government and governance. This is the time we should start realizing that we can no longer leave these things to other people to do and then begin to pick on the problems and live with the effects. But we have to think of what to do. We have to be in charge. We have to take charge. We have to begin to get into government. We have to think of getting into medical investments. By the end of the day, we have to probably think of getting into medical education as well. So there are investment opportunities, there are manufacturing opportunities, there are education opportunities as well, so that we can raise the next group and set of doctors. And then there are witnessing opportunities that come through this. Let me add, I'm going to be rounding up now, that a lot of people, doctors, have tried to run away from this problem, just not to infect themselves. If you were in the army, and you did hear when I was introduced, I was in the army. If you're in the army and a time for work came and you said you're not going, that's a big problem. That's a big problem. You know that in this country, even in the government hospitals, people have asked for people to volunteer. Volunteer if you want to work in COVID ward, volunteer if you want to do that, volunteer if you want to do that. It's not about volunteering at all. It's our job. Our job, particularly those of us that are hospital administrators, is to provide all the PPE that we need, keep people safe. But the job of doctors, and particularly Christian doctors, Christ-loving doctors, is to be able to give empathic care to people when they need it. So if you're out there, you're keeping your skills and not using them, that's not the best thing to do. You need to use your skills. You need to be safe. You need to feel safe. If you have underlying illnesses, you need to treat. You need to just treat them. But we need to bring our expertise to people at the point of their need. And I think that there's no other way to do it here than to actually apply our skills to be able to treat people who need that care. So I think that we've just looked at a few things. My prayer is that Psalm 91 will be our portion, that these pestilence and arrows that fly in the day will not come near us, even though 1,000 will fall by the left-hand side and 10,000 by the right-hand side. They will not come near us, and we'll be like the Bible says, first of all in Chronicles, and then it repeats it in Hebrews and talks about Abraham, Isaac, and Jacob getting to the promised land, and they knew it was their land. They knew it was the promised land. They had not yet inherited. They lived in tents, but God made sure of one thing. He provided them protection. He said, "Touch not my anointed, do my prophet no harm." I believe that if we do our work with a conscience, with the love of God, with Christ's love in us, God will protect us from all of these things that happen here. I know a lot of some doctors have died, and that is painful. I need us to take all the care that we can. We should teach our families how to take the care. We should teach our neighbors how to take care. And I believe that God's protection will abide with us. My prayer is that God will keep all of us so that we'll all be here at the end of this pandemic. And all of us would have learned a lot from it. It's not everything about it that is bad. but some of these have actually been opportunities, and that's why I was very, very happy to speak on this, that this may be our time, this may be our chance to turn the tides around. The healthcare space in Nigeria has been extremely pathetic. I'm a key player here in Abuja, and I see what goes on around. It's been extremely pathetic. We need to make things work. We need to make things move on. We need to find ways and means to support those in authorities to make sure that things actually move on and that we are all better for it. So thank you very much for listening to these, my few slides, just to show that there's a lot that we can do, both now, immediately, and then looking into the future. I don't believe, I'm not one of those who believe that black men don't plan. We can plan. So to be honest, if you're listening to me and you have the capacity to plan for the next 10 years, this is the time to start. We should be planning for next month, for 6 months, for 1 year, for 10 years. And this is the way that we need to look at it so that we'll be able to change the narrative for healthcare in Nigeria for the better. Thank you very much for your time this morning.
Thank you very much, sir.
Yeah, so I'll be available to take some questions, please. Thank you.
Thank you very much, sir. We would take the questions after this session. God bless you, sir. We are grateful. We've been blessed. I've gotten a lot of value. Talked about putting our trust in God, building capacity, investment opportunities. We should get involved in government, get involved in making investments. There are opportunities everywhere. Take advantage of this opportunity. Thank you very much, sir. God bless you so much. We would take the questions. I don't know if we have some questions. Technical team, please help me. If we do, we will take the questions immediately after the prayer session. We'll take the questions immediately after this prayer session. I would like to invite the person taking the prayer session, brother Dr. Stephen, to think of the prayers while we get the questions together. Thank you very much, sir.
Thank you very much.
God bless you, sir.
Thank you. God bless you.
Dr. Stephen, please, can we take the prayer session? Okay, I think we are ready with the questions. We would bring them in before Dr. Stephen starts. Please, technical team, can you help me? Can we get the questions? Can we ask the questions? Okay, as we gather the questions together, let's take the music. Can we have a low music at the background while we get the questions together?
If heaven are arms that they can swim, how great is the hope that lives in you? I see that cross, I see freedom. When I see that grave, I see Jesus. And from death to life, I will sing your praise. In the one, come on, you sing. When I see that cross, I see freedom. When I see that grave, I see Jesus. And from death to life, I will sing.
We were thoroughly blessed. We were so blessed. And it's a privilege to have fathers like you teach us. You know, I just got to understand that he was, our speaker was the one time NCCMDS University of Benin Teaching Hospital president. And
Yeah.
we are happy to have you again in this generation speaking to us, sir. We are grateful, sir. We are
Thank you
grateful.
so much. Thank you. Thank
I
you.
would like to welcome the Executive Secretary, Dr. Onoka, as he asks some questions while the other questions are being compiled. Thank you. Dr. Chimasa, Professor Chimasa. Professor Onoka, sir. I don't know if you can hear me. I want to welcome Dr. Professor Onoka for his question. Okay.
Thank you very much, Dr. Ogedengbe. I think, just very straight on, in a few minutes, it's related to your having served as a school president in NCCMDS then, now CMDA students. And this gathering is quite a huge one. You've raised the bar about issues, about envisioning, that can help envision people really. I really want you to tell us clearly, was this in your mind when you were a school president? How did this happen? Because there are many people who are wondering, can they really do this after, how many years? Can they actually get to this point of bringing such visions to pass? And then focusing on it, because there are many people here today who are where you were those days, and then a lot of people in between. So I wanted you to speak about that. That might actually help a lot, in a couple of minutes, to raise a lot of the stage as people take the steps to do what you have done as well. Thank you.
Yeah, thank you very much for that very interesting question. Yes, back in the day, in the 80s, I was president of the, no, actually early 90s, I was president of the NCCMDS. A bit of background, I came into Benin in 1987 and I left in March 1994. And in all those years, I was quite active in the NCCMDS. So I'm trying to find the right answer to your question. What's always been in my mind is to offer qualitative healthcare. I mean, that one there are no ways around. I think part of the problem is that many people settle for lower than adequate and appropriate quality because they feel it's not their fault. You see, it's either where I live or where I was brought up or what facilities I have to work with. So as soon as I finished my training in Nigeria, and I thought, well, this wasn't quite the type of orthopedics I thought we should be offering at this stage, where once I found the opportunity, and once God gave me the opportunity, I went abroad and tried to pick up a few things, and that helped. So the desire for quality, I think that is a Christian attribute that we must not let go. you do find Christians settling for a lot less, and that is not adequate. That is not good. Desire for quality should be top on our minds. It's quite possible that you will not find that quality in a ready-made place, and you might have to create something. So did I always want to create something, or create a structure like Cedar Crest? No, I didn't always want to do that, but I always desired quality. So when it was obvious that I wasn't going to find the quality I desired where one worked at the time, I knew that we had to create something. And creating things, after all, God is our Father. He's a creator. So creating things shouldn't be very far from our mind at all. And I think I like to encourage everybody listening to me that it's probably not as difficult as you think. You don't have to have so much going, and it's not that hard. So we have to put our minds on the things that are most important: competence, hard work, innovation, desire to make sure that you give qualitative care, not settling for less. I think too many people settle for less. If you have that, then you're going to find that irrespective of where you work, whether you work in a system that's already in place or you have to build a new one, then you will find that you're going to be able to make a lot of innovations. So the Bible says we are the salt of the earth. We're not supposed to take everything just the way we see it and sit, but we're supposed to make it change, and a positive change. So I think that desire for quality is what has helped. And I believe very, 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 very strongly that the only way you navigate things and keep your head up is to have your faith in God squarely. If you start to compromise with everything that comes around you, then you'll be in trouble. So God brings the opportunities and we use them. If you're not prepared, the opportunities will come and they will slip by. And then you keep thinking that is the environment. It's not all about environment. And I encourage us to read a lot. You read about other countries. There was a time that people in the US had to send children to the UK to school. People have gone through a lot of things. Okay, so we tend to think that it's easy to get things done. That's not correct. We need to be ready to pay the price. So hard work is also extremely essential. I think again, when you read the Bible and you see what people have put in as well, you'll be wondering whether it's the same God that they believe that we do, because they believe God and they went to work, but we believe God and we go to sleep, and it doesn't work like that at all. There are 24 hours in a day, and you have to use them well. So these are some of the things I think have driven one. But I would say that God brings the blessing, God brings the opportunity. It's not of him that runs or of him that wills, but it's of God that showeth mercy. But you must run and you must will. You don't sit and fold your hands because you say it is not of him that runs or it's not of him that wills, because that's not what the Bible was saying. You have to do what you have to do, and God will bring the blessing. So I've always, in a nutshell, desired to practice medicine properly, and where I thought it didn't exist, I had to do my best to create it. When I worked in London, I told myself, if this book can do it, then we can also do it. So I think we need to do a lot more with the life and the power and the opportunity that God has given to us. Thank you so much.
Thank you very much, sir. There is another question here. In places outside Lagos and Abuja, paying for services like healthcare is very difficult. How can these innovations be sustained in such environments?
Yeah, I read this question earlier, and I was wondering, trying to understand it, and then wondering how to respond. You say paying for healthcare is difficult outside Lagos and Abuja. Does that mean that it's easy in Lagos and Abuja? I think we need to probably, I don't know, the CMDA might hold a summit on this, looking at the entire healthcare value chain. It's a very long chain, and we need to start looking at that entire chain. Because sometimes people just look at one end. You say you go to hospital. What next? I don't know how many members are in CMDA, for instance, but you can very easily run an insurance scheme for CMDA. Very easily. It's not a problem. It's just to think about it and have a discussion about it. and it can be done. So if you then go for healthcare, you're no longer then having to pay out of pocket. So I agree that right now that most healthcare reimbursement is cash based, that it is difficult to get healthcare even in Lagos and Abuja. But these are things that can be discussed and people can find ways around them. We need to change behavior. People need to do less of throwing parties in any shape or form. And when I say throwing parties, don't begin to think of it as a bad thing. Birthday parties, whatever, weddings. If you invest more in healthcare, you get more out of it. So we need to shift some funds to the things that you don't see immediately, like healthcare. If you put some funds there for an association, you can easily create an insurance scheme that will look after members, and that's what's done outside here, in other climes. So we need to put value where value is and remove value from where value is not. You know, as much as I know, that there are extremely many church buildings in this country. So many church buildings, you cannot justify that. If you want to grow as Christians, we can't justify that. That is not spreading the gospel. So we build buildings and then we cannot look after people and they die untimely because of poor healthcare. That is not adequate. So there needs to be a reordering of priorities. And I think as Christians, we owe ourselves a duty to make sure we get good healthcare, make sure it's available to our people as and when they need it. So Lagos, Abuja, everywhere else, paying for healthcare right now is difficult. We can make these innovations. I think you're asking a question from an entrepreneurial end as well. If you put up a practice in Lagos or Abuja, will they? I mean, if you put up a practice outside Lagos or Abuja, will they be able to pay? People can pay everywhere. That's the truth. They can pay everywhere. Go and ask ShopRite if people are able to pay outside Lagos and Abuja. They'll tell you that they can pay. So if they can pay for things that ShopRite would bring from South Africa and put here, I'm sure that they can pay for healthcare. We just need to be a lot more organized. We're not organized at all. We don't discuss business in healthcare, and that's why these problems seem to be there. Thank you.
Okay, thank you very much, sir. Okay, thank you very much, sir. What would you say about innovation and medical advancements in Nigeria? Do you think it relies more on the private or public hospital vis-a-vis cost, affordability, and access to care?
Right. Innovations in healthcare in Nigeria. With all, and I'm saying this with so much respect for all of those who work in the healthcare place in the public sector. The truth is that public healthcare has its limitations, and that goes for anywhere in the world. One of the best public healthcare services in the world is the NHS, the National Health Service of the UK, and the limitations are still there. I think there should be a lot more private involvement, and not just private involvement in opening up a 2-room clinic and calling it a hospital, but private involvement even in research, in going around the existing facilities, looking for what the problems are, in solving them. Like I said, in insurance, in equipment, procurement, generation, manufacturing of minor things, in business support. So there's a lot that can be done that you really can't do directly through government hospitals, because they're a bit fixed in their ways, and it takes a lot more for you to change the way people view things in the government hospitals. I don't know a lot of places where most of the innovations have come from there. Even in the US, they had to throw it open and they let people be able to get, to work in certain private centers as well, because innovativeness is mainly private. If you wait for it to come from the government side, it takes a lot more, and it takes a lot more cost. So some of the things you do very cheap on the private side, on the government side, you're going to be spending a lot of money. And as well as I do, that the economy of most countries have taken a big hit, Nigeria inclusive. The UK is announcing about 10%, 12% drop. US is talking about 9% drop right now. It's going to be worse. If they were to look at the figures in Nigeria, it will probably be around 30%, if not more. So the ability of government to continue funding innovation and research is not going to increase and has never been there anyway. You know about the Abuja Declaration for Healthcare Funding. One is healthcare funding ought to be 15% of the budget. It's never happened. Max we've done is 6%. Two is even the little that is funded, what is it used for? Or two, you would say most of the budget is not released to healthcare. And three, that which is released, does it really go to healthcare? So these are problems that actually hamstring the government side from doing a lot as they should. So I think there should be a lot more private investment and private inputs. Thank you.
Okay, thank you, sir. Another question is, with widespread ineffective demand for healthcare, that is in terms of purchasing power, how effective will innovation in telecare be in bridging these gaps in healthcare?
Telemedicine and other innovations are very welcome. Okay, so if you take it from the basics, for us practicing here, I work in a hospital that is completely paperless, edge to edge. There's no paper at all involved, and I'm glad we did that, because when you now come to infection control and things like that, you now see that is actually very, very useful. Now, telemedicine is an advancement of the paperless environment where you're actually able to talk to people, further away, consult, and we're also doing that now. That's one of the innovations that can bridge the gap, because it actually reduces cost. I think we haven't approached healthcare as business people, and that's a problem. We should be looking at what our people can afford and trying to meet them at their point of affordability. And that's what healthcare should be doing. That's what our approach to healthcare should be doing. If we do that, you find that telemedicine will have a big role, because somebody can sit in front of his phone, the same phone he's using to waste all the time doing WhatsApp every day, and he can see a doctor, and the doctor can usually see some red flags and say, well, you're going to die if you don't go to the hospital and do this. Then he runs to the hospital. I think that telemedicine can really be used with the amount of the internet availability in most parts of the country now. I think that's a very good thing. So the telecommunication, telephones, and the internet service has spread to the point where now we can use it to our advantage, and it can actually reduce costs. So it's something we should really be thinking about. And there are some of us doctors who are extremely smart with the computers, extremely smart, can innovate. Guys, please go to town, go work on things, show it to people who are practicing like us. Let's provide something that can really help to bridge the gap. I believe so, but have in mind that we should have what patients can afford as one of the things. They've done that in some parts of India, asking the question, what can patients afford? And then you now try to bring the cost down to what the patient can afford. Not spend all the money in a prototype way and expect that patients will pay your cost, and when they don't have, you say, well, there's nothing I can do. I've tried my best, I close shop. So we need to look at a lot more business engineering to go with what we're doing. Thank you.
Okay, thank you very much, sir. We still have lots of questions, but because of our time, we may not be able to take them all. Okay,
No.
one last one before we go to the next program. The issue of financing is a big barrier for capital-intensive specialties like oncology, but equally problematic in people's ability to pay for services. How do you balance this when you think of investing in cancer care?
Yeah, it's a good question, because we have been thinking in our practice, we've been thinking of investing in cancer care. Again, the way I like to see it is we just don't have options. We have to invest in cancer care for our own selves, for our people, for our friends, for our family. We have to invest in cancer care. And the outlay of cancer care right now in Nigeria is very poor. There's not a lot out there. Like I mentioned during my presentation, there's no PET scan. If there's no PET scan, you really haven't started dealing with cancer care yet. And I'm not sure, when I started doing the research, I really worried why people are buying linear accelerators up and down the country and nobody thought of a PET scan. You have to have that, for instance. Is the finance a big issue? it's a big issue, but it's not the biggest issue. So do we have enough people? See, we are 200 million people. And I keep hearing this that people can't pay. But I go to the UK, I see Nigerians lining up. I go to India, I see Nigerians. I actually see them physically, not that I hear of them or I'm told. I see them lining up. I visit the US, I see Nigerians lining up. So it's not about people can't pay. People can pay for these services. It's how we do the business planning that's a problem. Many people have opened up some facility somewhere and nobody knows about it. How are they going to go there? How are they going to pay? Some people would say, I have a piece of land in the backyard somewhere and I'll go put a hospital there. You can't do that. You have to, before you put one block on the ground, you have to do a lot of business planning. You have to ask yourself, where is the most ideal? If you have, so it's not healthcare planning and healthcare investment is not for where I have land or where my father gave me land. No, that's not the idea. That's not the idea. You have to do, I think we have to do a lot more planning. Once you plan, you find that people can pay for services because the countries where we go for healthcare, people who will go to see there, they planned. They planned. The way you get from Heathrow to London and where they planned it all out before you came, before you even born, they planned it. So we can't just jump in and expect that things will happen. That's not correct. So to answer the question, financing may be a problem, is not insurmountable. There are leverages now. There are bodies, organizations ready to finance things, including cancer. Cancer care is expensive. Investing in cancer is expensive, but there's finance available. And there are patients in Nigeria out of the 200 million lot of us that can pay. Once you get the business plan right and you do it all right, and then the next thing you'll be thinking of is how do you accommodate people who cannot pay? That's a secondary problem. But I can assure you that a lot of people, I'm inundated daily now, more than before the COVID era, even in the COVID era, with patients who have cancers and who cannot get care locally. So I think it's a good area for investment. Thank you.
Thank you very much, sir. Please, we cannot continue with the question and answer section because our time is fast spent. I would like to appreciate you once again, sir. But we can, if your questions are not yet answered, please, you can send them to him as a private message, and I think he will be able to answer or type something for you. Then, in the course of the program, if we still have the time, we will take more questions. But right now, we'll go into the prayer section. I want to invite Dr. Emmanuel to take over the prayer session. Thank you very much, sir. God bless you, sir.
Thank you so much. I will do my best to answer all questions that reach me. Thank you so much. Thank you. God bless you.
Thank you, sir. Bless you.